So yeah, we're really glad you're here. My name is Ashley McClure. I'm one of the co-founders and co-directors of Climate Health Now, along with Amanda Milstein. We're glad for you to be joining us on this Monday at your lunchtime hour. And the theme today, as you know, is about the plastic polycrisis and what we can do about it. And if you wouldn't mind writing your name in the chat, pronouns if you want, and then where you're zooming in from, that would be wonderful. So we always like to start our meetings with our mission, which for Climate Health Now, our mission is to organize and mobilize the California health community to advocate for equitable systems-level climate action, linking arms to make change together in the interest of health and equity. And Climate Health Now has 3 areas of work. We kind of build our base of members across California. We welcome anybody in the health community to join us, and we do community organizing, kind of helping to build up the leadership capacity that we all have within us to really become effective climate health and equity advocates for solutions. We do a lot of advocacy at the legislative level, at the state level. And then for today's theme, of course, is catalyzing healthcare sustainability, because, you know, as we all know, healthcare contributes something like 8 or 10% of US greenhouse gases, and we have a big role to play in decarbonizing it. And that's what we really appreciate our amazing leaders. So we have both Pam Lee with us today and Bill Pevec, and together they are the co-chairs for Climate Health Now's Healthcare Sustainability Resource Team. Pam Lee is joining us from UCLA, and Bill Pevec is joining us from Davis. And we love the work they're doing. They're doing a lot. We'll actually mention the Healthcare Sustainability Fellowship that they're coaching this year. And I'm going to turn the floor over to them to talk to us about plastics and what we can do about it, about the crisis of plastics. Can you share? Okay, Bill, you going first, right?
Thank you.
Yeah.
Ashley, should have my slides up, yes?
Yeah, they look great. Terrible and great.
Yeah, terrible and great, thank you. So I have no disclosures for this presentation. As a brief outline, I'm going to start discussing plastics in our environment, then plastics in healthcare, then plastics in us, in our bodies, and then Pam's going to talk about how we can reduce plastics in healthcare. And if I can ask everybody to mute, please. So the problem really started in the 1950s, and the plastics industry started pushing disposable plastics on the community. This is from Life magazine, which many of you may be too young to remember back when magazines had a big impact, but Life magazine was a very popular magazine, and this is an example of the plastics industry pushing disposable plastics on the public, saying, look, this great, we got throwaway living. The objects in this photo would take 40 hours to clean. No housewife needs to bother. You just throw this stuff away when you're done with it. How great is that? And as a result of this, plastics production skyrocketed, really started significantly in the 1950s, but you can see it gradually and rapidly increased in the 70s and 80s, and then really now in the 21st century, up to 400 million tons of plastic produced globally every year. And to give some perspective, we look at just one type of single-use plastic bottles. 1 million plastic bottles are sold around the world every single minute. If we took the plastic bottles sold around the world in a single day and put them in a pile, that pile would be half as tall as the Eiffel Tower. And if we took the single-use plastic bottles used in 10 years and put them in a pile, it would form a mountain 1.5 miles tall that would dwarf Manhattan. And this is a problem we're not going to recycle our way out of. This looks at the plastics produced over 65 years, 1950 to 2015. 8.3 billion tons. 2.5 billion tons are durable plastics that remain in use. That's not really the problem. The problem is the 70% of plastics, the 5.8 billion tons of plastic that are single-use plastic that gets used once and then thrown away, either put in a landfill, incarcerated, or littered. Only about 6% of plastic ever produced has been recycled. The vast majority of that gets used one more time and then goes into the waste stream. Only about 1% of plastics that has been recycled and remains in use. So recycling is not the answer to this problem. And healthcare has a major part in this. The average US hospital generates greater than 4.7 million pounds, that's 2,300 tons of waste every single year. And a big hospital like the one I used to work at, UC Davis Medical Center, creates 17 tons of waste every single day. Phenomenal number. I've had to go back and recheck that multiple times. That adds up to more than 6,000 tons per year. So it's a really significant problem. And this is from Kelly. I got this information from Kelly Wright at Cedars-Sinai on one of her presentations. And she investigated who is the biggest waste producer in Los Angeles. And it turns out it's her hospital, Cedars-Sinai Medical Center. And according to Kelly, major hospitals are frequently the biggest single source of waste in any municipality. And 30% of the waste hospitals produce is plastic. Some estimates show it's even higher than that. The global plastics medical market is huge, $22 billion annual industry, and that is growing by 6% per year. And not surprisingly, the US is a consumer of almost half, 40% of the global medical devices produced. And this is from an interesting article. This is looking how plastics got into the healthcare system. And it really was important to the advances of healthcare. If you look at most of these innovations happened in the 1930s to the 1950s. And these are really important things that changed how we treat our patients. Catheters, tubes, heart valves, vascular grafts, cardiopulmonary bypass machines, dialysis machines, all these really high-tech, complex things that we use to take care of patients now rely on plastics. But that's not really the problem. That's not what we're talking about today. We're talking about how single-use, simple plastic stuff has permeated healthcare over the last several decades. And how has that happened? It happens because this is frequently an efficient way to do things, like the prepackaged sterile kits that we use for putting in central lines and so on. They're very convenient and efficient. There is some economic sense. It's often cheaper to buy a disposable item than to sterilize reusable items. There is a widespread perception that single-use plastic stuff reduces infections, although that is not well substantiated at all. And it's simple. We have just grown into throughout our lifestyle of being habituated to using disposable stuff. We like to just use something and throw it away because it's easy. And a big factor in the rampant expansion of plastics in healthcare is the plastics industry. And this is a quote from the Plastic Industry Association. Removing plastics from healthcare would put patients and healthcare professionals at risk. Currently, plastic is the best material in terms of cost-performance ratio for the healthcare industry, but also, it bears repeating, it enables the provision of the safest, fastest medical care available today. Healthcare costs would be higher if plastics were excluded from healthcare. Infections would be more common and more difficult to prevent. Most, if not all, of that is not substantiated by any evidence, but this is the line that has been the drumbeat of the plastics industry over the last several decades, pushing plastics into the healthcare system. Okay, well, so what? Well, the problem with plastics is that plastic breaks down into smaller fragments, but never truly decomposes. And the other problem with plastics is it's very lightweight. So plastic floats and it moves through the air. Give one problem is plastics getting into our oceans. 8 million tons of plastic enter the oceans every year. That's the equivalent of a city garbage truck dumping its load into the ocean every minute, 24 hours a day, 7 days a week, 365 days a year. There currently is about 150 million tons of plastic in the ocean, and that plastic will soon outweigh the biomass of all the fish in the sea. And these plastics get everywhere. Microplastics have been found on the top of Mount Everest and at the deepest depths of the ocean. And these microplastics get into our food chain. And we're going to really focus on the smallest particles, which are microplastics defined as fragments under 5 millimeter in size, and even more importantly, nanoplastics, which are less than 1 micrometer or 1/1000th of a millimeter in size. So the plastics that we use goes into the landfill. We get plastics from our laundry. Fragments of our synthetic fabrics get into the wastewater from our laundry. It gets into the streams from our tires. Multiple different uses result in these tiny particles of plastics, which get dispersed into the air and also dispersed into the soil. From the air, there actually plastics has been shown to transpire into the leaves of plants. The plastics in the soil get into the plants. Animals eat the plants, and the plastics, the microplastics and nanoplastics get in the food we eat, the plants and the animal protein that we eat, and then it gets into us. Similarly, these plastics get into the ocean, are taken up by seafood, by fish, and then when we eat seafood, it gets into us. In addition, plastics are in our water, so when we drink water, we get plastics into our system as well. In addition, microplastics and nanoplastics are in our cosmetics, in our toothpaste, in our baby products, and all those things directly can introduce microplastics into our systems. And this is a study that was just published a few months ago in the Proceedings of the National Academy of Science. And these two investigators looked at plastic particles in 3 very commonly distributed brands of bottled water. And they found every liter of bottled water contains 240,000 plastic particles, just incredible. And most of those are the smallest, the nanoplastics, which can cross and get out of capillaries and get everywhere in our bodies. And this is a really troubling slide. This is a review of multiple studies looking for micro and nanoplastics in human tissue. And micro and nanoplastics have been found in human lung, in bronchoalveolar lavage, and in sputum. It's been found in human blood and clot. It has been found in the liver, spleen, kidney, and colon. They have been found in the placenta and in breast milk. They've been found in the stool of adults, the stool of infants, and even fetal stool, meconium, and also in our urine. So these microplastics and nanoplastics are all over our bodies. And a really frightening study also just published this year, we're just starting to learn how harmful these plastics might be to our systems. So in this study, they looked at 304 patients undergoing endarterectomy for asymptomatic carotid disease. And they found polyethylene in 150 or 58% of those plaques, and polyvinyl chloride in 12% of the plaques. And then they followed these patients. And over the next 3 years, they found that the combined endpoint of heart attack, stroke, or death was 4.5 times higher in patients with micro and nanoplastics in their plaque than patients without micro or nanoplastics in their plaque. The confidence ratio, the confidence interval was 2 to 10, so did not cross unity, highly statistically significant, suggesting that these microplastics are not good for our cardiovascular health. So in summary, we get plastics in our systems from the food we eat, and it's not just eating food that's packaged in plastic. These microplastics and nanoplastics are found in apples and carrots and vegetables and meat and fish and virtually everything we consume. And also microplastics enter our systems through our medications, as I mentioned, through our cosmetics, and also through airborne dust. The micro and nanoplastics get in our system by ingestion, swallowing them, by breathing, inhaling them, or transdermally through our skin. And it's been shown that these plastic particles lead to inflammation, cancer, direct particle toxicity, and oxidative stress, which then lead to a whole multitude of health problems. And in addition to the plastic particles themselves, plastics usually are commingled with a bunch of harmful chemicals that make the plastic more flexible, increase the properties that the manufacturer wants the plastic to have. And many of these compounds that are attached to the chain of the polymer chain of the plastics are highly toxic. And when the plastic gets into our bodies, these toxins also get into our bodies and can then be released from the plastic. And this is a really harrowing paper published a few years ago, looking at these endocrine disrupting chemicals found in our plastic medical equipment. So the authors found phthalates, BPA, parabens, perfluoroalkyls, and triclosan in syringes, venous catheters, TPN infusions, endotracheal tubes, blood bags, cardiopulmonary bypass circuits, and infusion sets. And these chemicals are associated with reproductive, neuropsychiatric, and metabolic disorders. So these very important items that we use to care for our patients may actually be introducing harm into our patients as well. And then in addition to the plastics that are directly getting into our systems, the production of plastic releases all sorts of horribly frightening toxic chemicals into the environment. The photograph on the left is an ethylene cracker plant. That's a plastics production plant. And the photo on the right is a photo from East Palestine, Ohio, where vinyl chloride train derailment occurred, and then just burned that vinyl chloride and poured all those toxic fumes into the atmosphere. And those toxins that are involved with plastic production have been associated with multiple very significant health effects, as are outlined on this slide. And we are paying a huge price financially for the health effects from these chemicals. These chemicals are adding billions of dollars to our healthcare expenses. So in summary, plastics are ubiquitous in the air, the water, the soil, and our foods. Plastics have also become ubiquitous in healthcare. Micro and nanoplastic particles are in our tissues and may carry along with them other harmful chemicals. Harmful chemicals in plastics can leach out of the plastic and into our systems. And in addition, the manufacturing of plastics releases toxins into our environment. So if we truly care about the health of our patients, it is our priority that we must try to reduce plastics in healthcare. And Pam's going to discuss some ways we might consider to do that. Thank you.
Geez, Bill, it's really depressing, but thank you. I just want to give a shout out to Kathy Gerwig, who is joining us, who actually wrote the book called Greening Healthcare, and retired from Kaiser, where I first learned of her leadership in this area. So we'd love to hear from you at the end, Kathy, and excited to have you, Pam. Please take it away.
Okay, can you guys see my screen in full screen mode? Okay.
Perfect.
All right, everyone. Thank you so much, Bill, for that. That was a really wonderful talk. I'd already seen your slides, but I feel like I still learned so much. And, as you were talking, I was kind of reflecting on how you sort of got the fun part, right? You got to like scare everybody and make them feel like this is really, really, really challenging and scary and dangerous. And now my job is to try to lift everyone back up and make us feel like we've even got a shot at this. So as was mentioned at the beginning, I'm an infectious disease and infection control specialist in Los Angeles. I didn't put a slide in here, but I likewise have no disclosures. So, we titled our talk this Polyethylene Polycrisis, right? And I wanted to spend a minute on that and talk about what a polycrisis is. I think when this talk kind of stemmed out of Bill and I emailing back and forth and talking about this really complex interplay of our ecosystems, of the climate, biodiversity loss, human health, pollution, all of these different things. And I think as we were sort of brainstorming this talk, this word polycrisis seemed to just really fit a lot of the things that we were talking about. So a polycrisis is defined as a cluster of related global risks with compounding effects such that the overall impact exceeds the sum of each part. And the World Economic Forum developed this pretty scary graphic here that has all of these different crises and how they link to each other in this gigantic polycrisis. And so as I was developing my slides for this, I started sort of thinking about my personal polycrisis, if you will. I know I just said that a polycrisis is supposed to be global, but bear with me for a moment here. So as I mentioned, I spend a lot of time doing infection prevention and control, right? So I think about things that are in that sphere. I think about outbreaks, nosocomial infections, pandemics, vaccine hesitancy, all of these things, antimicrobial resistance. And now, as I've gotten deeper into this climate space, I also start thinking about the relationship to things like pollution, to climate change, and then of course, all of the interrelatedness of things here. So we're going to spend today mostly talking about this infection prevention and control component, because as Bill has pointed out, this is an oft-cited reason for the generation of waste in healthcare, specifically plastic waste. If you haven't seen this talk, it's done by Dr. Jody Sherman, who's really a pioneer in the healthcare sustainability world. It's linked at the bottom there. And she makes this point that infection prevention has been driving this trend towards excessive single-use disposable devices and waste. And I think the perspective of myself, as well as other infection prevention and control folks out there who really care very, very deeply about planetary health, is that this is a viewpoint that we are eager to change. And why do I think that that change is not only possible, but necessary? You're going to have to bear with me again for these next few slides here. So I've always kind of wanted to use a sports analogy in one of my talks. And the reason for that is when other people use sports analogies, I'm usually very lost because I really only pay attention to one sport, and that sport is gymnastics. So if you're a gymnastics fan, or even if you aren't, you have probably heard of this woman. Her name is Simone Biles, widely acknowledged as the greatest of all time, right? Now, who you may not have heard of is this gymnast, Rebecca Andrade. She is a wonderful Brazilian gymnast who has had an equally amazing career to Simone's, maybe not as many awards, primarily driven by injury. Now, Rebecca and Simone last faced off in the 2023 World Championships, and during that competition, Simone fell on vault, performing her eponymous Biles 2 on vault. And immediately following that, all of the headlines, they love to drag on Simone, unfortunately, but they came out with all of these headlines. Oh, denies Simone Biles another world's gold, outperformed by Rebecca Andrade. They, of course, had all of these pictures where Simone looks really, really serious and Rebecca looks triumphant, right? But this is their actual relationship. They're friends. And what Rebecca has said is that I believe people fabricate this rivalry. She said she's thinking about retiring, speaking about Simone, and I said, don't do it. We need you. So where am I going with this? Well, of course, you've all heard this before, right? Rebecca Andrade and Simone Biles are just like healthcare sustainability and infection prevention and control. We cannot do this without each other. We need to find ways that we can partner. So what I'm going to spend the rest of my time here talking about, after somewhat ham-handedly inserting my first ever sports analogy into a talk, are ways that we can partner with infection prevention and control to try to reduce plastic waste in healthcare. And I'm going to focus on two of what I consider to be more high-yield topics within infection prevention and control. However, I would not say that this is by any means comprehensive. And of course, there are other ways that we can try to partner as well. So let's start with the PPE talk. So we know that personal protective equipment, especially in the time of COVID and maybe post-COVID, I'll knock on wood a little bit when I say that, accounts for a tremendous amount of plastic waste. So in this waste audit that was done in Massachusetts, they found that PPE accounted for close to 70% of plastic municipal solid waste on an inpatient medical ward during a 24-hour period. And this was done in 2023. And you can see from this that precaution gowns were a huge part of that, right? So we're really going to focus on that component, on the contact precaution side. So to give a little bit of background, why do we use these contact precautions, these single-use disposable gowns and gloves? Well, according to the CDC and HICPAC, the reason that we do this is for patients who are known to be infected or colonized with certain epidemiologically important pathogens, which require additional control measures to effectively prevent transmission. So the question that we have from there, of course, is, are all of the pathogens that we currently use contact precautions for epidemiologically important? And even more critically, are these contact precautions effective? When it comes to things like MRSA and VRE, it's actually quite controversial as to whether or not these are effective. I'm not going to go through everything on this slide, but just know that there are a lot of sites that do not use these contact precautions, do not use single-use disposable gowns and gloves for these particular organisms for a variety of reasons. So what we've been looking at in LA County is, are there ways that we can work with our healthcare facilities to try to reduce the waste from these contact precautions in particular? To give you an idea of the scope of gown and glove use for contact precautions for MRSA and VRE in LA County, what we found during some studies in the last year is that about 7.3 million total gowns are used per year for MRSA and VRE contact precautions across LA County. So that's one single county in the United States. Granted, it's one of the largest ones. This is accounting for acute care hospitals. Notably, this is probably an underestimation because a large number of our skilled nursing facilities also do use contact precautions for MRSA and or VRE. And also, it does not account for nighttime gown usage because this data was collected by doing observations of patient care, and we did not do patient care observations overnight. So just a tremendous amount of waste is generated from these contact precautions use. And when you take that number and you start looking at environmental parameters, what you find is that hundreds of thousands of kilograms of solid waste are generated per year. And when you look at life cycle assessments of these gowns, that comes to, it's a pretty wide range, but several million kilograms of CO2 equivalents yearly. And when using sort of a middle of the road US-based life cycle assessment that assigns each single-use disposable gown made of non-woven polypropylene 310 grams of CO2 equivalents, this equals about 255,000 gallons of gasoline, 286 homes energy use per 1 year, and 5.8 million miles driven by an average gasoline-powered passenger car. So these are all environmental impacts and plastic waste that is generated from a practice that is, I would say, highly controversial in terms of its efficacy and may also have important effects on both patient and staff well-being. So for this reason, in LA County, I've actually been working with the LA County Department of Public Health, and we've conducted a series of webinars with our healthcare facilities, urging them to reconsider whether or not these contact precautions are actually necessary. I've linked the website that we've been using to spread this information up at the top. I can drop it in the chat later as well. But there are a variety of materials on there. There are some lectures that were given, PowerPoint slides, all of that sort of thing. So what I would say is that one way that you can consider decreasing the amount of plastic waste in your facility is thinking about contact precautions. It really is one of a potentially high impact category and something where you may be able to partner with your infection prevention and control team to better both sustainability, improve financial costs, and of course, impact patient and staff well-being as well. Okay. So we're also going to talk about reprocessed medical devices, and Bill alluded to this a little bit in his talk as well. So what do we mean when we say reprocessed medical devices or reprocessing? These are the steps taken to clean, disinfect, and sterilize reusable devices. Notably, this can be done in-house through central sterile processing or via third-party vendors such as Medline or Stryker. We're really going to use this sort of as an illustrative discussion of reprocessing. We can certainly get into the details of anything in more sort of one-on-one discussions, but I think that the goal of this section is really to talk about, again, how can you partner with infection prevention and control? What are some infection prevention and control specific considerations when thinking about this switch, going from something that is single-use plastic disposable to maybe going to something that can be reprocessed? So reprocessed medical devices have been repeatedly shown to have lower environmental impact and financial cost compared to single-use disposable devices. They're also less vulnerable to supply chain disruptions. So that kind of begs the question, why do we even use single-use devices? I would love to hear, if you guys want to vote in the chat, which of these three answers most resonates with you. Is it because the upfront cost is cheaper? Is it because the manufacturers want to sell us more, like Bill alluded to, so they make more single-use versions? Or is it because infection prevention and control makes us? Give you guys a few seconds to vote. I haven't looked at the chat yet. I'm honestly a little bit afraid to. So I'll take a look when we when we move on and when I can look at the chat.
Mostly B.
Mostly B. Okay.
Although I like Hillary's answer of all of the above.
It probably is all of the above, Hillary. You're exactly right. All right. Okay. Interesting to know. All right. So let's say that you have decided that this is something that you want to do. You want to be able to move from some sort of single-use disposable thing to a reprocessed, reusable version. What are some considerations there? So I think one of the first things that you really want to do is critically think about the stakeholders. And I've listed a by no means comprehensive list at the side there. I think you want to think about ways that shifting to reprocessed items can actually improve your workflow. If you can demonstrate that, that is powerful, right? And if there is no way that is possible, how do you use that as an argument for more resources? For example, Do you tell your C-suite, hey, we do not have enough people who can do central sterile processing. We do not have enough people who can collect these materials. How do you use this as an argument to get more support, potentially for infection prevention and control, potentially for central sterile processing, something like that, right? So I think that there are ways that you can make this hopefully a win-win situation for your different stakeholders. And the last point, and I do want to emphasize this, especially from the IPC standpoint, patient and staff safety is paramount, and you're going to have to pick your battles, okay? Ideally, we keep moving towards a circular economy. Ideally, we think about ways that we can make everything in medicine more sustainable, but there are times when you're going to come up against something that your facility is just not really going to want to move on. So an example I like to bring up here is single-use versus reprocessed endoscopes, right? So there were famously some very impactful nosocomially transmitted infections and multi-drug resistant organisms related to reprocessed endoscopes that occurred a few years ago. And unfortunately, people died from those infections, right? And a lot of that, and some of that, I should say, may have driven some of the changes to single-use endoscopes. However, it's again, something where there was a tremendous patient safety issue balanced against a very challenging environmental issue. Those endoscopes are resource intensive. They take a lot of time, energy, and so on to manufacture. So that may be an area where, despite the environmental impact being really large, if your facility was one of those that was impacted by those patient deaths, that may not be the one to move on right now. And that actually gets to a really important barrier to using reprocessed devices. One huge barrier is that we don't have great epidemiologic data on how many healthcare-associated infections occur because of reusable devices. And Bill alluded to this. We completely acknowledge the data are poor. However, until we have better epidemiologic data, it may be really hard to try to quantify the risks and benefits associated with the environmental impact of single-use devices versus the patient safety, specifically the infection risk. Additional barriers include a lack of society guidelines. We need more detailed guidelines. This is something that I think is going to be an active area of change in the next few years. And those guidelines need to include things like standardization for cleaning, validation, and remediation. As Bill has pointed out to me, the third-party vendor sites are very regulated by the FDA. So this would be more something that relates to the individual in-house reprocessing. Another barrier is that we need staff who are familiar with reprocessing techniques. This paper examined the education, training, and knowledge of infection control among endoscopy techs and nurses. And what they found was that despite pretty extensive experience in healthcare, a lot of the respondents only scored around 60%, or on average scored around 60% for their endoscope reprocessing knowledge. So these are processes that require education, they require ongoing education, I would say, and this has been a barrier that I've noticed in my own facility and have heard about from others as well. And then finally, and again, coming from an infection control perspective here, I do want to kind of emphasize that there is a need for infection control presence, more infection control presence when you go to these reprocessed devices to oversee those processes. And I think there is sort of this sense in the IPC community that this is not necessarily something that everyone can take on right now, especially coming out of the COVID pandemic, right? So this paper just kind of demonstrated some of the themes that were identified among infection control professionals during COVID. And they noted things like feeling depleted, like guidelines were changing all the time. I think we can all relate to that, whether we're an IPC or not, as well as a lack of recognition and support. So, coming from my angle, again, I think that working with sustainability is actually an opportunity for infection control, an opportunity to get more resources, to get more personnel, and get more enthusiasm behind what we're trying to do. So to sum up a little bit, why do we even use single-use devices? I think that we can say, as of right now, it's easier. And I think one of the most important questions that we can work on as a community is how do we get to a place where being sustainable is easy for all stakeholders? That's really what we should be trying to do. Some take-home points. how much time do, oh, we still have a little bit of time.
Yeah, you're good.
I'm not gonna read all of these out. I would just kind of emphasize IPC is a critical stakeholder, important partner. If you are interested in doing a project at your facility, I encourage you to reach out to IPC earlier rather than later. I would say that one of the most important drivers for IPC is patient safety. Unfortunately, another one is regulatory oversight, right? So those are two things that need to be considered in all of these projects. And I would say that for me, some of the areas that I've been able to kind of find the most ground in reducing plastic waste and pollution is through working on infection control related things such as contact precautions policies, as well as employing use of reprocessed and reusable devices. Thank you, everyone. I love including this on my infection control talks. It's me in a plague doctor mask. I was not at the hospital. I was at the Renaissance Fair.
I love it. Yeah, Pam, hats off to you for the most amazing sports analogy ever. Thank you. A big round of applause. We have some time for questions. If anybody has any, come off mute and go ahead and ask either Pam or Bill if you have any.
I see Brenda's question in the chat, which I was wondering the same thing, is IPC generally only an inpatient or hospital-based service, or is that also happening in outpatient clinics?
Yeah, what a great question. So it is primarily hospital-based, and it really originated from nosocomial outbreaks of Staph aureus infections. However, as healthcare has increasingly shifted to the outpatient setting, there has been a need for outpatient infection control. The problem is that there are not great outpatient infection control guidelines. So I can actually speak to this a little bit from my experience because I got pulled into doing outpatient infection control during COVID. And the problem was because we did not have outpatient infection control guidelines, we had to use the inpatient ones. And those are so much more conservative. For example, things like testing your water system for various waterborne pathogens, right? That can be really important in the hospital where you have transplant patients and highly immunocompromised patients living in the healthcare facility. They're living in the hospital. It's a completely different standard when you have them healthy people coming into your clinic, right? But they're kind of held to the same standard, which just doesn't make any sense. So this is something that I think ID and infection control really need to work on, is infection control in all these different settings. Yeah, Brenda, sorry, I thought that might have been your question. The ambulatory surgical centers, I think, are one site where they specifically do have to align with the inpatient surgeries. So, yeah.
I see Terry's question in the chat. If you wanted to start with a small instrument or an item that's currently plastic to shift to a reusable, what would you choose?
I can take that one on. It depends on what your goal is. If you want to make the single biggest impact with one switch, it would probably be switching from disposable to reusable isolation gowns. As you can see, they add up very, very quickly. I put in the chat, Pam talked about 7 million isolation gowns in LA County. I know our own hospital in the 2020-21 COVID year, we used 1.8 million isolation gowns. And we actually are still in the process of shifting from disposable to reusable. And that effort actually started because of supply chain concerns during the COVID, the height of the COVID outbreak, when we just couldn't get the disposable gowns. As far as if you are looking for something that's easy, it depends on what you have to pick something in your work environment. I don't know, Terry, where you work. If you wanted to get rid of a single small instrument, it depends on what you're looking at. But the things that you need to do if you want to make that transition is you need to talk to your supply chain folks and find out if there is a reusable alternative. If there is, how much it costs, and if it's something that needs to be sterilized, then you also need to talk to Central Sterile, see if they have the capacity to handle that. you need to talk to materials management to find about storage and how you're going to move those things around your facility. So that's why I said the gowns. So gowns are a big project, but they're actually logistically frequently simpler than a device that needs to be sterilized, processed, stored, and distributed throughout the hospital. So
If I can follow up on that, and then we'll go to you, Hillary. Bill, if somebody was looking for help with making the business case for disposable gowns, would you have any examples? Or Pam?
that's always your best way to get your first inroads, is if you can show you can save money and not harm anything. That's a easy, that's co-benefits, an easy thing to get across the finish line. When we did our analysis for reusable versus disposable gowns, we found that we would have a significant cost savings. We did a pilot in our pediatric ICU and estimated we'd save about $3,000 a year. When we extrapolated that experience to the hospital, we figured we'd save about $125,000 hospital-wide per year. So it usually is cost effective to switch from reusable to disposable, from disposable to reusable gowns.
Awesome. And then I don't know, we'll go to you next, Hillary. Bill and Pam, if you want to put your contact info in the chat, but if anybody wants to get in touch afterwards, you can always email us. Just to name this, it might be obvious, but you can email connect@climatehealthnow.org or email directly to Bill or Pam. Hillary, great to see you. Go ahead.
Good to see you too, and thank you, Bill and Pam, for that excellent presentation. I've been thinking about the plastic crisis a lot lately and how healthcare contributes to that. If I have my stats right, I think 70% of healthcare plastics are from plastic wrapping, and that's across any department, outpatient and inpatient. And the argument, I think really more coming from industry and our kind of strategic purchasing department, is that we need the plastic wrap because it's sterile and the instruments are clean. So I haven't heard any sort of counter argument that or any evidence behind that. And so I think it feels like a very steep hill to climb and a steep battle, but how do we even decouple this idea of sterility and cleanliness? Everything needs to be wrapped in plastic, and help and start to think about how do we reduce our reliance on plastic wrappings in healthcare?
Great question.
Pam, do you want to take that on? I'm happy to.
Yeah, I can start. Decoupling that idea is going to be really, really hard, right? Like, it's not a healthcare specific problem, I would say, as part of it. It's a kind of worldwide consumer problem, right? You go to the store or whatever, you're like, oh, this thing's wrapped in plastic. It must be really clean. So there's a perception problem there, I would say. If you were to ask an infection preventionist, how do you prove that, or how do you sort of decouple that idea? They would probably want some sort of insane infection control study that would be far too difficult to do. I think that this is why knowing who the stakeholders are and kind of working in a concerted effort as healthcare providers, as end users, is so important, because this is something that we would need to really change from the get-go, right, throughout the supply chain. At least that's my sort of big picture overview. I don't know if, Bill, you have some more practical tips on that.
Well, I've got a couple there. There are two different aspects to what you're asking, whether you're talking about plastic packaging and how things are delivered to us from outside versus putting plastic on top of things in our hospital ourselves. The packaging is a complex one because there are regulatory policies where you have to maintain sterility and integrity of the product. And it turns out that the product itself, making that product, usually has a much bigger life cycle imprint than the packaging does. So if you end up wasting 10%, you switch to a less plastic or no plastic packaging, that seems great, but you end up wasting 10% of the supplies because that packaging is not impermeable. You end up having a bigger environmental impact from making that 10% extra supplies and putting 100 plastic wraps on all of them. So there are serious considerations on the integrity of packaging, and it's a difficult thing to address because it's a national problem, international problem. So would be very difficult for a single healthcare system to get a manufacturer to change their packaging. It's something that I've been trying to push on a national level through the Medical Society Consortium, but haven't really gotten any traction on that yet. The second one is there's all sorts of ridiculous internal policies with plastics. We had one at our hospital where out of the blue, this came, I think, from the Joint Commission, dinged us or something, that when you had a bed with clean sheets on it that was not in the patient room, it had to be covered with a big plastic drape.
Oh my God.
Yeah. And we fought that one, and we got pushback from the Joint Commission. There's other things when we have sterilized our endoscopes, they had previously gone in reusable hard covered trays. Well, they started putting them in, wrapping them in plastic also, and there's pushback on that. So there's lots of internal illogical plastics mandates that one can work on, but as terms of packaging can be more challenging. Still a battle that we need to address, but a more challenging one.
So it sounds like we have a series coming. We're talking about the bio-based plastic issue. And then I saw a question. Yeah, Clean Med, that's a great point. Annie, good to see you. Clean Med is a annual conference put on by Healthcare Without Harm that gets into a lot of these topics, issues. Was there maybe one more question, and then we'll move on to our closing and our opportunities for getting more involved?
Sounds like there's a few questions about like alternatives, and I missed the initial thing on bioplastics. Yeah, I think Bill and I could probably talk about that a lot. I feel like the issue with a lot of these things is just reduction rather than switching to some of these alternatives. Gloves I could go on and on about, but actually in the study we did of MRSA and VRE, we also looked at MSSA and VSE, right? So things for which theoretically you should need standard precautions, hand washing. And the amount of gloves used was almost the same between the two groups. So people just put on gloves just to like go into a room and look at a patient. It's kind of absurd. Anyway. Yes.
The probably the biggest impact one could make with gloves is appropriate use. It used to be, or at least before COVID, I don't think most doctors put on gloves to do a standard physical examination on a patient. But then they got in the habit of doing that, and there have been studies showing how the use of gloves has just skyrocketed for every little tiny thing where they are no benefit. And the trouble is, those plastics don't compost, and I don't know that there's any good alternative if you really want to have a barrier for a glove other than the current vinyl plastic gloves. I think that's kind of it. So the idea is just to not use them inappropriately is the most important.
I still see people grocery shopping with them. Seems like an inappropriate use.
Yeah.
But thank you so much to Pam and Bill. We really, really appreciate your teaching us and sharing what you've learned and done in your different centers. So a big round of applause. Not in tuxes, but thank you. And then now I'm going to pass it to Brenda to talk about the Healthcare Sustainability Fellowship.
Hey, everybody. I'm Brenda. I am so happy to talk about this. So Bill and Pam, as you all have seen already, are amazing, amazing people, and they are leading our very first cohort of the Healthcare Sustainability Fellowship through Climate Health Now. And so currently we have 3 teams that are moving their projects along with Bill and Pam's support and advice and mentorship, personalized coaching. We have a team from Kaiser Santa Rosa Family Medicine Department working on food and healthcare. We have Abhinav, who is at UCSD, who is working on waste in pain procedure suites. And we have Layla at Kaiser East Bay, who is working on scope 3 emissions reduction in the operating room. And so stay tuned. We're going to be getting a presentation by our fellows at the end of the year, probably then the beginning of 2025, so they can present to all of our membership about their projects and their outcomes and processes. And so given that this fellowship has been going really, really well in, building this educational component and also this action component of doing healthcare sustainability actions within a fellowship with the support of Bill and Pam, we will be opening up applications for the fellowship for our second cohort in 2025, and the application will be coming in October. So stay tuned for that, and we'll have more information.
Ooh, great. And then Amanda, you want to talk about the new Slack workspace?
Yes. Hello, everyone. Okay, so this is something we have been thinking and talking about for a long while, and I'll admit I am nervous and excited to be sharing this with all of you. We are going to pilot a Slack workspace for CHN members specifically interested in healthcare sustainability. I'm not going to go into all too much detail right now, and we'll have lots more information forthcoming and opportunities to learn about Slack. But the idea here is that we are looking to build a space where CHN members can share information, they can connect, and they can collaborate specifically around healthcare sustainability projects, with the goal of seeing more change made where we actually work and where we need to see this change. So how can we, take oh my gosh, we have such a problem with X, all the way to look at the change we made at our workplace. So Ashley, if you can go forward one slide. Awesome. So I'm going to share the link in the chat actually right now for how to join our Slack workspace. We'll share this out again via email, as well as a bunch of other resources related to this. If you have used Slack before or use it for other work, then a lot of this will be redundant, what's in the guidelines that we'll share, but essentially we'll kind of walk you through how to get up to speed on Slack, and then how to find what's called channels that you're interested in, that we have organized according either to the setting in which you work, the type of sustainability project you're interested in, and more. So we hope that folks will be interested in this, and we're really excited to be bringing it to life, and to make it useful to all of us. And then one last slide, Ashley. Perfect. And so next Monday, and I'll share this link in the chat in a second, if you are interested in getting a casual and interactive tutorial on how to use Slack, Brenda and I will be running that from 12:30 to 1:30, but we will also record it and share it out. Brenda and I are going to be moderating our Slack workspace for the next 2 months. And so we'll be around to answer questions and to help folks with any of the tech side things. And here's the link to register for that.
Awesome. And yeah, I think, and Amanda, in the discussions about it, the inspiration, and I appreciate, Amanda, you're creating this space, is for our CHN members to have a place where we can kind of do more peer learning and share more resources, because we're not aware of other spaces like that are kind of interactive within peers. So hopefully it's useful, and we'll see how it goes. So thank you. All right. So I'm going to close this out just a little bit, talking about some of the other work that Climate Health Now is doing. And we have this year, in addition to, kind of the healthcare sustainability work and the community organizing work, we also have the advocacy work, which, we call that kind of going upstream to more towards the root of a lot of things related to climate change, which is of course related to fossil fuels and plastics. But this year we have 4 campaigns that we're participating in at the state level, and they're campaigns, introduced in the state legislature that are all about climate, health, and equity. And what we're doing is bringing our Climate Health Now members, anybody in the health community, public health, health administrators, clinicians, everybody in health in California, bringing our voices into advocacy for state policy, because there's a gap there. And we, every time and time again, when we join coalitions, we really hear that when people in health join, that it really has a big impact on decision makers and policymakers. So the 4 campaigns that we're working on are really exciting. One, SB 252, is about requiring the world's largest pensions, which is CalPERS and CalSTRS, the state's teachers and public employees, divesting their pensions from fossil fuels. Another one that we're working on, ACA 16, is about adding to the California Constitution an amendment that would make a right to clean air and clean water a universal right. Not written in right now. We have a right to health, happiness, and liberty, but not clean water and air. So that's a really basic but potentially very, very important one. Another one, AB 1866, is about cleaning up idle wells. So California is the 7th largest producer of oil and gas in the country. And a lot of the oil wells in California are old and not producing as much, but they're not properly capped. And so they're leaking methane and many other toxic, not only greenhouse gases, but toxic chemicals. And as you can imagine, they tend to be in historically redlined communities, really kind of adding fuel to the fire of health equity and environmental injustice. So we're working on a bill that would require the owners of those wells to clean them up in a very basic way. And then the last state campaign we're working on is a referendum. And so it's going to be on everybody's ballot in November 5th. And it's a campaign to keep the law that all of us already passed, that's related to having health and safety setbacks between where oil extraction happens and where people live and go to school and preschool and where people are. So after that law was passed, the oil lobby funded petition gathering, signature gathering, and a referendum because they're trying to squash, the process that already happened and overturn it. So we are standing up against them, and we really need some help. So if any of these call to you and you're like, oh, I want to see what that's like, I want to get involved, we would love and need your help. And Amanda just dropped in the chat a link. And so if any of those pique your interest and you just kind of want to see how you could help our team leaders, these are the leaders for each of these campaigns. We would love that. And you can share your interest and then kind of get plugged in for upcoming opportunities, of which there's lots and they're fun, in the chat. So just finishing up, we have about a minute. There's a lot coming up. We have a webinar May 8th. So that's actually next Wednesday, if you can believe it, about how important it is for everybody to vote as a determinant of, health and climate action, just getting civically engaged. We have, for anybody who's newer, we have a meeting for anybody who feels new and is interested. We have a meeting May 15th that's specifically focused on new members and kind of getting you oriented in the evening. Our community meeting we have monthly is going to be May 21st. We have a discussion club, which is kind of like pop culture, kind of podcast, documentary, integrating climate, health, and just getting to know each other more. And that will be focused on plastics. And that's going to be Wednesday, May 22nd. And then just we have a lot of things happening related to our advocacy campaigns, too many to mention, but we will share them with you in a specific way if you share your interest about any specific campaigns. And then the very last thing is we always are open to feedback. We definitely tried to cultivate a growth mindset in Climate Health Now, where we're always learning and growing. So if you want to share your feedback about this meeting, what could have been better, what was totally awesome, please let us know in our short 5-question feedback form, and we will take it to heart and try to grow from it. So I see, Bill, you said 2 invitations to the meeting, May 21st. Is that lunchtime or 5? Let me see.
Your slide just said 12:30. I have on my calendar 2 invitations, one at 12:30, one at 5. So I'm not sure what is the correct time for that meeting.
The correct time for the May
12:30.
community meeting is 12:30.
Yes, sorry, Bill. We will take the 5. We originally thought we would try it at 5, but we reconsidered. Sorry.
So it's 12:30.
Yeah.
12:30.
Thank you.
Yeah.
All
But thank you so much to Pam and
everybody.
Bill. You really rocked it. I can't believe Kathy Gerwig joined. That's really cool.
And we're going to send out a big recap later today, and we hope to see some of you on Slack.
Hey.
All right,
Woo-hoo.
bye, everybody.
Bye.